Welcome to the second episode of the Rubaiyat Khan for Endless Health podcast. And today I'm joined by two amazing friends and colleagues. I'm super excited to host both of you. I will go through the formal introductions first and then talk about you more informally. Uh, Today we're joined by Dr. Rob Coram, Chief Medical Officer of Penda Health in Nairobi. Rob trained in internal medicine at Mass Gen Hospital in Boston before moving to Kenya, where he has spent the last decade leading work on quality improvement and patient safety. Under his leadership, Penda has served more than 2 million patients and published widely on innovations in delivering high quality, affordable primary care in low resource settings. We're also joined by Dr. Madeline Pesek, MD. She's faculty with the primary healthcare program at Ariadne Labs at Harvard and a physician in internal medicine and pediatrics. Our research focuses on population health management, hypertension care models, and health equity in low and middle income countries. She's an expert on Costa Rica's primary healthcare system, which we'll talk more about. And she's studied the impact of primary care reform, implementation strategies, and measurement for improvement. So with those formal introductions out of the way, I'm super excited to talk about non-communicable diseases with you today, because that's what we've worked closely on. Just for background, from Endless, we had the great privilege of working with Dr. Rob and with Madeline on a program called BP Sawa in Kenya. And we're now also collaborating quite extensively on the population health management framework. So we'll dive into those models and we will learn about what makes them exceptional in handling the crisis of NCDs. And we will then talk about what this means for the overall health system design as we figure out how to handle this massive crisis that we have on our hands. So I will actually start off with Madeline, but before that, just a little bit of context. We all know that non-communicable diseases or chronic diseases, as they're more commonly referred to, kill more people than infectious diseases globally already. And that's something that has been true for at least a couple of decades. And unfortunately, most of global health financing still goes primarily towards infectious diseases and definitely not as much towards chronic diseases as they should. So, Maddie, my first question to you is to help us paint a picture of how big NCDs really are. Tell us a little bit about how our health systems are currently failing to address this massive crisis across both maybe developed and developing nations, where you have experience across both. So would love to kind of get a more vivid picture of what this actually looks like in practice.
Absolutely. So first, just to underscore the magnitude of the problem that we're facing, worldwide, over 70% of the deaths from non-communicable diseases happen in low and middle income countries. And yet, like you alluded to, only about 2% of the global health funding goes toward non-communicable diseases. By 2030, for example, in Africa alone, NCDs will overtake infectious, maternal, and other causes of death to be the leading cause of death. And about 45 million deaths happen annually from non-communicable diseases. 18 million of those are premature deaths under the age of 70. So this is a problem in low middle income countries, in high income countries, across the board. And I think when we try to understand why we have failed so massively to adapt to this looming and what seems to be obvious need, I think a lot of it comes back to the way that we conceptualize what a doctor is, what a healthcare system should do, and when it's time to engage with a healthcare system. For so long, everyone conceptualizes going to the doctor as something that you do when you don't feel well, right? When you have a symptom, when something wrong is going, you expect to go to the doctor, tell them about what's ailing you, and then they'll give you something to fix it, cure it, make it feel better, and then you'll go home. And that interaction only happens when things aren't going well or when something's wrong. And so I think one of the challenges is to reimagine how we view interaction with the healthcare system. And we've done it in pediatrics, right? We know that kids need checkups at the doctors, whether they're feeling well or they're not feeling well. And somehow that conceptualization of what going to the doctor means really hasn't translated into the adult population. I think there's some other challenges with global health in particular that have really slowed the adoption of interventions to address non-communicable diseases. I think there's a perception that non-communicable diseases are diseases of affluence that only happen when a country has the money to have its people have hypertension or diabetes or obesity. And we know that's not true, but unfortunately that's still a sentiment that is pretty widespread. And then there it's really hard. There's a complexity of dealing with these diseases where it's a much easier answer to go to the doctor, get an antibiotic, feel better, and go home. That's easier to operationalize. That's easier to execute. These longer term, longitudinal relationships with a provider where you're negotiating really hard stuff. You're negotiating, how do you eat? How do you sleep? Can you make time for exercise? Those are bigger, harder, longer conversations that take a lot more effort.
That's really wonderfully put, Maddie. So I hear a few points which we'll dive into more as we go through the conversation. I think one thing that I picked out was this massive gap between what is the reality versus what is the perception, right? So NCDs are so big, yet 2% of financing goes there, right? It is complex, it is relational versus the way we deal with health systems and create what is actually a sick care system. It's not really a true healthcare system. The sick care system is actually transactional, whereas what is needed is much more relational, right? So we're going to pick out more of these themes as we talk about it further. But just to make it a little bit more vivid for us, Rob, coming back to you, you have a frontline care experience in Kenya, network of clinics in Nairobi. You face the burden of NCDs every single day in your practice, right? So can we hear a little bit from the front lines what the NCD burden actually looks like in a low and middle income country?
Yeah. I mean, Dr. Maddie, your answer was beautiful and high level, and I hope that I can bring two stories to help illustrate what it looks like in Kenya on the front lines. One story is from when we started our BP Sawa work. I was at one of the 4 branches that we piloted that work in. And it's a busy branch. It sees, maybe 100 to 150 patients a day. And the morning that I was there, a family brought in their elderly mother who was maybe late 60s, and she was having a massive stroke. So she had to be carried in. Half of her face was paralyzed. She couldn't move, her leg and her arm. Her blood pressure was through the roof. She was in really bad shape. And it was really scary for everyone, right? It's really scary for the family, of course, for the patient. And then I think even for our staff to see someone in such a critical condition. And, of course, we activated a referral pathway right away and got her to the national hospital. But I think it really drove home the point for us of why it's so important that we have programs like BP Sawa and we start working on this larger problem of shifting the healthcare system from a sick care system to a preventative care system. Because once it gets to that point, there's very, very little we can do. And that's, the case in any country. Really important that we put in the work, 20 or even 30 years before that woman has that outcome. So I think that's one story that's happening that really illustrates this is happening and it is starting to affect families and people are starting to see it. Now, the other story is a patient who comes in for, an elbow pain and has blood pressure of 150. And we say, oh, wow, your blood pressure looks a bit elevated. Has anyone ever said you had high blood pressure before? And he says, yeah, I had blood pressure a couple months ago, but I took meds for a week and, now it's better. And I think that's the other story that really illustrates that there's a long way to go in terms of the general public just understanding, what does it really take to treat these conditions? Because the sick care mindset is still so prevalent. And a lot of that is from a patient perception, which is, I have a condition, I take a medicine, I feel better, and now it's over. And that's just not how the management of non-communicable diseases really works. And so I think that's an important story to really recognize how much of an uphill battle we all have in terms of what it will take to solve this.
Thank you, Rob. That's been my experience as well. And I think when we talk about NCDs, poor people have almost a double burden, right? They have the burden of the disease itself, but then they also have the burden of ensuring that they put food on their table and they have prioritized the things that are of importance on a daily basis for them, right? And so whereas affluent populations could have the luxury of taking the preventive steps and having their medications so that the symptoms don't escalate, for a poor person, really making that investment includes trade-offs, right? And that trade-off often becomes the problem that people just cannot prioritize NCDs until the symptoms become too complicated, or the stroke patient, for example, that you shared, Rob. There's so many of these themes. I'm so excited to dive into these themes and potential solutions with you. But before we go into your models, I'd love to hear a little bit about your personal motivation to invest time and effort in this space, because this is so difficult. And as clinicians, I'm sure it is much easier to see a patient who comes in and then give them an antibiotic and they feel better and go home and smile, right? Whereas really investing the time and effort to create programs that you might need 10 years before you even see results. Like, what drives you? What motivates you?
I think that the epidemiologic burden is so obvious when you look at it from the numbers. And though that kind of investment in making that relational change can be more time consuming, it's also much more rewarding as a physician to work with someone for 5 years to bring their A1C, or a marker of the sugar levels in their blood, down from something like 13%, which is incredibly dangerous, to something like 7%, which is much more on target. That goal setting together, that motivational interviewing techniques, and the relationships that you develop with patients over time through a process like that is incredibly rewarding and provides a different kind of satisfaction than handing someone an antibiotic and knowing that they'll be better by tomorrow. I also think that I have a little bit of a thing for the underdog, and I see NCDs as very much someone that we need to fight for and something that isn't getting the attention that it deserves. And like we talked about in the introduction, it's harming patients. And so I think many of us as physicians will go where the need is, and the need to work on NCDs and to do this better is so glaring when you start to look at the numbers.
Coming back to you, what motivates you, as I was asking?
Yeah, I mean, the whole reason Penda was founded actually came from a very personal patient story of a baby who was a family friend of ours who had been bounced around between different clinics when he was sick. And he was malnourished and kept getting different infections, pneumonia, etc. And although each time the clinic treated the pneumonia and addressed the acute health issue, no one was really following along and making sure that he got the nutrition support that he really, really needed in order to prevent all of these things. And he ended up passing away at 6 months old. And it was like really quite devastating. And that was the reason that Penda was started. Penda actually started about 6 months after his death. And so I think it's not just NCDs such as hypertension or diabetes in adults. It's really thinking about what are all of the different things that we need to do that can only happen through that kind of continuity of care that ultimately like achieves better outcomes for people. And we don't have little 6-month-old luckies who pass away before their time.
That's heartbreaking. But unfortunately, so many of these stories abound. And I've had personal experiences with similar things in my family and extended networks as well. So we will, with that as background, we would love to dive into the programs and the models that you have developed, which are cutting edge and extremely innovative. Tell us, Rob, we'll start with the VP Sawa program because that's what we all worked on together. And would love to hear from you about the program, why we started it, how it actually ended up addressing this massive challenge of NCDs. And we know that we are now scaling it up across all of your clinics. Like, what gave you the confidence that this is working and that it is actually worth rolling out to your 2 million patients? Over to you.
Yeah. So, I mean, I think when we sort of first formulated the idea for VP Sawa and why we need it, we looked at just the burden of high blood pressure. And within Penda's clinics, we see about 1,000 to 1,500 patients per day, and we've treated over 2 million patients over our 10 years. And we see that about 20 to 30% of our adult patients actually have high blood pressure just based on the values that we record in the triage area. And when we looked at whether those folks are actually managing their blood pressure, that is like lifestyle modifications, taking medicines, etc., we found that only like 2 to 3% of people with high blood pressure were actually taking those medicines. And so it was just like, wow, there is a huge gap here in terms of this is a problem that we're seeing every day across all of our branches, and we're just really not addressing it. And when we started to dig in more on why that is, I mean, it's very multifactorial, and I'm sure we'll get into that more in this whole discussion, but part of it certainly is awareness. Like the story I shared, people don't necessarily understand that this is like a long-term thing that they're going to have to manage for years and years. Part of it is on the health system side. Are we as healthcare providers and nurses and doctors, et cetera, looking for this? Are we aware of the best and most affordable ways to manage it over the long run? Are we good at having the conversations with the patients? And how are we educating them? How are we explaining it to them? And then are we making this affordable and scalable for the patients? Because there's many of them. Like I said, there's hundreds every day that we need to be thinking about. And so I think it's very ambitious to try to tackle all of that. And I think we did some of those pieces really well. And some of those pieces, I think during the scale up, we have a big opportunity to improve. But I think what gave us the confidence to actually scale it was just in that initial pilot over 4 branches. Even just in the first few months, one of the things that we found is that we were able to connect remotely with about 70% of those patients. And we use WhatsApp really extensively at Penda, so that's how we communicated with them remotely. And a lot of what we would do is just remind them, hey, you had high blood pressure on your last visit. We'd love for you to come back in and get the blood pressure taken again. And, again, we didn't get as much as we wanted, but 40 or 50% of those folks did come back in for a follow-up blood pressure. Right. And so you can then think of it like a funnel of, are we getting the next blood pressure? Are we doing the next step to, define their degree of hypertension, lifestyle management, medicines if needed, and then ultimately following up to make sure the blood pressure is controlled, which is ultimately the goal. That's one big funnel. And I think we have a lot of room to iterate at every single one of those steps. But I think seeing the initial numbers and what a big change we could make, even in just those 4 branches, and the scale that produced. I mean, it was thousands of patients who went through this just at 4 branches, just in the span of a few months of that pilot. So that's what makes me really excited for scaling this thing up.
That's super exciting. And I'm hearing from you that essentially what we're doing here, and I just want to highlight this for the audience, that oftentimes we see healthcare as discrete between different encounters with providers, right? Someone walks into a Penda clinic, that's an encounter. The next time they come back with another sickness, that's another encounter. That's all of healthcare, right? What you're truly doing here is bridging that gap between the clinic and the home and back to the clinic, right? You're creating that continuity between those care interactions so that patients are in the loop of care wherever they are, even when they're back home. And that's, I think, super exciting from an NCD perspective and any sort of care perspective. I think patients, and I'd love to hear your thoughts on this, but I think patients also feel cared for when they're asked, right? When they're asked how you're doing, why don't you come back, right? Like that really gives them a feeling of care that the provider is showing. So I'm curious about a couple of things. So one is around what are the different kind of treatment or management pathways that you're seeing working? So is it more in terms of medication adherence that you're seeing some results in? Or are you also starting to see indications that because you're doing this proactive follow-up, there's changes in lifestyle or behavior, or you're able to bring some of the markers under control? Of course, it's too early to tell, but would love to hear any data that you can share on that. And then the second piece I want to hear from you, Rob, is how is this aligned with your business model? Because you are a clinic, you get paid for a visit. So how do you see this really serving your business model? And as a private company, how does this line up?
Yeah. I mean, one of the really interesting things for me in my career journey, moving from medicine into more like entrepreneurship, I've learned a lot of things about business. And one of the things that you do in a business is you think about a sales funnel and you think about how to optimize each step of the sales funnel. So where are people dropping off, and, what might I need to do to nudge them to get back into that funnel? So we think about that a lot from more of the business perspective. But when I was working on this program, it really drove home that like a lot of this type of sort of population health management, which we do in medicine for NCDs, in some ways it's a sales funnel, because we understand that there are various barriers that people face as they move down that funnel. And we need to keep iterating on each level of drop off. Right. So if I send a message and, I say, I'd love to have you come back in so we can check your blood pressure, and no one responds to that, I think almost like an old school public health approach is like, they're lost to follow up, too bad, like, let's focus on the next. And I think with your sales hat on, and this kind of gets to your second question, Rubaiyat, is like, I'm really incentivized to try to get that patient to come as far down that funnel as I can. And so that makes us think almost again in this very entrepreneurial way, like, is there a different type of message that we can send? What if we send like a short second TikTok video of one of our doctors talking about blood pressure? Will that maybe be a motivation? Or, is the frequency of the message, is the timing of the message right? So those are all the ways that we're trying to innovate to try to drive folks down that funnel. Now, for the first part of your question, where are we seeing the biggest impacts? I think medication adherence, we still have a ways to go on. And that just gets back to, again, the idea of the funnel. Medication adherence is when you're all the way down at the end of that funnel. We've diagnosed you, we've talked to you about lifestyle, we've talked to you about medicines, you've started a medicine, and now we're at the adherence level. And so for our pilot, we just don't have tons and tons of people that's like all the way down that far in the funnel. So I think with the scale up, adherence is going to become a much more significant part of what we do. During the pilot, a lot of it was how do we move people down the funnel to get back in, be aware of hypertension, and sort of start the journey of, hey, this is something that I need to manage.
Super interesting. I love how you connected the proactive population health management with the sales funnel approach. And I think that's a connection that very few people make. In fact, I did not make before we started on this project. And one of my biggest questions, if you remember, was how will this proactive follow-up and all of this line up with your business model as a traditionally passive clinic, right? Where people are expected to walk in. So I think that was probably one of the biggest lessons for me and for us in this program, that this proactive follow-up actually drives patient loyalty. It drives repeat visits, and therefore it's actually aligned with the clinic business model. And I think that's such a big revelation for the entire space, because so much of global health and is about facilities that are just sitting idle, waiting for patients to walk in. Put in that extra effort to go out into the community or to reach out through things like WhatsApp or TikTok, and people actually showed up more. That would have helped move the needle on MCD so much more, but unfortunately, we're not doing it. I think there is a mental gap there in terms of connecting the clinic business model with the sales funnel approach that you so beautifully did there. I want to ask Maddie a little bit. Maddie, you were quite closely involved in the entire BP Sawa program, and I realized that we did not actually articulate what BP Sawa means. So in Swahili, BP Sawa means BP, blood pressure, okay. Which was the name that you guys coined through a lot of intense design exercises. So Maddie, what was unique about the BP Sawa program from your perspective as a researcher and as a clinician? And what were the key lessons and takeaways, aside from what we already talked about, for the overall ecosystem with respect to NCDs from this program?
Thanks so much. It was such a pleasure to work on BP Sawa with Penda Health and with Dr. Rob overall. I think that one of the unique ways was the way that the program was designed and developed. This wasn't an intervention that came from a playbook from another place that we copy pasted. The premise of developing BP Sawa was that we would not assume anything. We would say, why does this gap exist? We interviewed patients, we interviewed providers, and we did a lot of work in the design phase to really understand why patients are dropping off at each level. What are the barriers to getting to medication adherence, to getting to diagnosis of hypertension? What's currently going on? What are providers' attitudes about how we should make this better? And I think that human-centered design and patient journey mapping throughout their experience with hypertension really enabled us to design an intervention that fit the system and fit the context and fit the patients and fit the providers. And that intervention is not going to be the same in every place. But I think the steps that we went through of first understanding what the problem is before parachuting in with a stock solution really enabled the program to be responsive in design and then responsive over the course of the pilot. And as we transition from pilot to rolling it out more broadly, it enables us to embed patient voices, clinician voices, and even staff. I mean, we interviewed maintenance staff, we interviewed front desk staff, we interviewed the call center to see what their perspective on this entire hypertension experience was like. So that point of designing not just for the provider, but also for the patient was a really beautiful experience to go through, even though it does take a little bit of work. And I think the other point that really stood out to me is that the specific clinical pathways that are designed are not the point. The hard part about the intervention is a mental shift, like we talked about, in terms of what patients expect at each clinic visit and what providers offer at each clinic visit and how the provider sees their role. Of course, it's important to prescribe amlodipine for high blood pressure, but all providers are really good at following these pathways and figuring out what the next step is. And that's a very surmountable challenge. What's exciting, what's invigorating, and what's a little bit more challenging is figuring out how to reframe the way providers see their role in a clinic visit. That their job is not just to prescribe the correct medication, that it's their responsibility, their privilege to understand what motivates the patient. Do they want to be able to bend over and pick up their grandkids in 10 years? Are they an artist? Do they like to paint? And is the concern of developing blindness from uncontrolled blood pressure what's really going to motivate them? So figuring out what makes each patient tick, what matters to them, and then being able to pair that with evidence-based intervention for hypertension. That's a new skill that most providers don't get taught in school. And it's an exciting shift that is going to underlie all of this shift toward proactive care in redefining what providers give and in redefining what patients expect. So like you said, when patients receive their follow-up call, there was some concern that they would feel like, why are you calling me? What do you want? My blood pressure is fine. Why are you bothering me? And that wasn't the experience. That many patients were delighted to have someone check up on them, to follow up with them. And it helped underscore the point that this is important and we care about your blood pressure and we want to work together to improve it.
Maddie, we'll now move on to the population health management framework, which broadens the lens a little bit on this topic. And the way I first came across your work was through the research that you did in Costa Rica, which showed 13% improvements in all-cause mortality through a comprehensive primary care approach. So I'm really curious to hear how you reconcile what we did in the BPSAR program with the broader population health management framework, and where I want to specifically ask you about the concept of empanelment, which you talked about as one of the basic foundations of how to do population health management. And yeah, just tell us a little bit more about the framework and how it fits with what we did in BPSAR.
Absolutely. So when we think about population health management, it can mean a lot of different things to different people. If you're in the United States, it's often connected with reimbursement and insurance rates. From a public health perspective, it can mean something different. And so really trying to reconcile and say, what is at the core of this population health management technique that is so different from the old model of providing care and is at the heart of our ability to manage long-term chronic diseases, whether those are communicable or non-communicable. And I think population health management can seem very overwhelming and something that you need a lot of fancy technology to achieve. But what is so beautiful about the Costa Rican experience is that they did this all with pencil and paper, and eventually some Excel spreadsheets. But I just want to underscore that as we get into the details of population health management, there's a lot of opportunity for technology to accelerate that process. But I just want to highlight that at its most basic, this is not a fancy digital solution. This can be done by hand. So when we talk about population health management, I like to think, what is the population that you're trying to serve? And that's that first step of empanelment. Who are you taking care of? When we ask you, what percentage of your patients with high blood pressure have achieved blood pressure control? What's your denominator there? Without knowing exactly how many patients you are assuming responsibility for, all of these calculations and tracking over time becomes a lot more challenging and really difficult. So that's the first step, is define the population that you're taking care of. The second step is assess their health, right? How are they doing? Where is the burden? So this is exactly the step that Dr. Rob described, right? He said, when we looked at our numbers, we found that 30% of our patients had high blood pressure and only 2% of them were controlled. That is a step that not many CMOs take. And so just to highlight that that's what Dr. Rob was doing in that moment, was he was doing population health management. He was looking at the health outcomes across his system. And then he was taking the third step, which is the management part, to say, how do we make this better? How do we improve where we are to where we want to be? And then that relationship between the assessment phase and the do something phase is iterative. And you want to check in to say, did our pilot work? Did we achieve our goals? Did the patient outcomes change? And I think so much of global health is centered around measuring things that aren't about the patient. And we measure a lot of stuff. We measure dozens and dozens of indicators across hundreds of countries that aren't at the patient level. And I think population health management really reframes around patient outcomes to say, do you know your population, to measure their outcomes, and then do something about it? And that's a pretty simple concept that, feels like maybe we should have been doing this earlier. Unfortunately, in many places, we're still stuck in this passive model where we wait for patients to arrive, we do the best we can, and then we send them on their way.
No, that really does strike a chord, because when we started Endless Health, we started off with some questions and explorations. And one thing we realized eventually was that the niche that we really wanted to build on was this idea of people-centered design, right? Really focusing on the patient, their needs and aspirations. And it is so ironic that that has to be a niche. That's supposed to be how it is done across the space. But it was so obvious, blatantly obvious that that was not being done, that we eventually picked that lane for ourselves. And that became the thing that we built our entire portfolio around. And I think you're highlighting something similar, where people are just not seeing at the patient level, like hundreds of millions of dollars of loans from the World Bank goes to country governments for health systems reform. And then the outputs that are measured are often the number of clinics that were developed, right? Or the number of providers that were trained, and not about whether we actually achieved anything meaningful with patients. So super salient. I also want to highlight what you just said about population health management not being something only governments can do, right? So when you talked about how Rob did it, I think there's a concept that population health management or anything of that sort can only be done at the public health level, where you enumerate your entire population, make sure you do like household surveys and identify every single individual and name them, right? But that's not necessarily how you have to do it. Rob had the system. Of course, they were further ahead than most healthcare systems in terms of having an EMR system where they could just pull out that data. But any health system has records, right? And using those records, you can actually pull out what is your denominator and what percentage of that has a particular condition or not. And that's something I think that's a really important reframing that I just want to put a pin on.
Rubaya, if I could even take that further and say, any individual clinician can do this. When you look at your own patients that you've seen and you're like, hey, does this person need anything? Is there anything else I could do? That's population health management. So it doesn't even require the health system level, much less the public health apparatus.
That is a really wonderful point. Yeah.
And I would just add on to that to say, as we think about developing a population health management framework from an academic standpoint, we really grappled with this. And a lot of the feedback that we got said, gosh, your framework is too flexible, right? It can't operate both at the national level and at the individual provider level. And that was something that was really frustrating, because I think it's so essential that we see this responsibility to improve health as the responsibility of every single person in a healthcare system, right? It is just as much the individual clinician sitting in front of the patient to make sure that they have done preventive care alongside their curative care, as it is the branch manager of the clinic to review all of the clinic numbers, as it is for the CMO to review the whole clinic's numbers, as it is for the district of the city of Nairobi and the country of Kenya. And it can be done at any level. And ideally, it works best when everyone is rowing toward the same outcome, right? When issues that are identified on a national level can then be filtered down to the provider level. And I think that is what enabled Costa Rica to do this so effectively and efficiently, even while it was all happening on pen and paper. And so because each individual physician, in their case, took care of about 3,000 to 4,000 people, had a list of all their patients with diabetes, had a list of all their patients with high blood pressure, a list of their children with malnutrition. When the national government asked, how is our country doing on controlling high blood pressure? It was an easy exercise to sum up the lists and the registers from their clinics, and they could work toward the same goal at the national level all the way down to the provider level. And that makes the whole system better in alignment toward whatever goal it is that is contextually, momentarily relevant, whether that's dealing with a pandemic of COVID, whether that's addressing non-communicable diseases, or whether that's a particular area seeing a rise in syphilis and needing to respond and adapt to that.
Yeah, that's such an important point. I want to come back to the Costa Rica experience a little bit more in detail, because I think it is such a a compelling case of this being done well. And of course, with technology, as you said, there's so much more we could do across so many other countries. When you looked at the data, the 13% mortality reductions that were actually seen, do we know what percentage of that was from like NCD related deaths or other things? Like it would be good to get a perspective on where it was having the most impact.
Absolutely. So when we look at the numbers in Costa Rica has an incredible data infrastructure, as I've alluded to. And so they have tracked every single death in the entire country since prior to 1982. So our data started at about 1982 and went forward until 2015, I believe. And so we were able to have an incredibly rich data source on cause of death, place of death, age, gender, even socioeconomic status by other proxy measures, which really enabled us to do an incredibly robust study. And I was able to work with a phenomenal researcher who at that time was based out of INCAE, which is Costa Rica's business school, Dr. Claudio Mora, who really conceptualized this project and drove it forward. But what we found was that Costa Rica had an excellent mortality rate to begin with. So we were worried initially that once you drive down a huge amount of the easy mortality, you're stuck with this more recalcitrant mortality that is harder to budge on. But we saw that the places that they were making the largest mortality gains were really unexpected and exciting. So we had a 19% reduction in cardiovascular mortality and a 22% reduction in mortality for the elderly or those over 65. And we know that once you get to 65, the majority of your disease burden falls into the non-communicable disease category. And that was really invigorating for us. And we saw that drop over 10 years. So this is the other point that I want to highlight and what makes non-communicable diseases a little bit more challenging to show that patient outcome change. We can look at intermediate markers like, is your blood pressure controlled today? Is your sugar level in the blood controlled today? But it takes at least 10 years. And like Dr. Rob alluded to, in order to prevent that woman from having a stroke, she needed to have controlled her blood pressure for the previous 20 to 30 years. So the timeline that we're looking at is fairly long, and it's longer than most investors want to talk about. It's longer than most venture capital folks want to talk about, and it's longer than most global health grant making organizations are comfortable with measuring. And so that's another burden that if you're treating pneumonia, you can do a 6-month study and show the change in mortality. If you're treating hypertension, you need a much longer time aperture. But they did see that by impaneling, by tracking, by monitoring, they were able to reduce this mortality piece much quicker and a much larger scale than we actually thought going into the study.
Just talking about, so of course, empanelment is an important step. Measurement is an important step, but ultimately it's about the management that ultimately leads to the results, right? So if you could talk a little bit about because once they knew that people had multi-chronicity, multimorbid conditions, or somebody was, let's say, elderly, what was actually being done at the care team level that was different that ultimately led to the results? And I think if you could tie that back to the population health management framework and talk about like what motivated them to actually do that. I think because so many other health systems also probably know that they have patients like this. Why don't they do it, right? Like that is an important question. So what made Costa Rican care teams so much more effective?
So in terms of the motivation piece, I think that the Costa Rican healthcare system is very unique in that in 1995, they combined their public health infrastructure with their clinical infrastructure to be one organization. And so that has given a very public health perspective to the way they run clinics, the way they run hospitals in a way that other countries don't have. So I think that their public health brain is always on the population level to identify the places where they need to be working. But once you get down to the individual patient level, they have a beautiful multidisciplinary team model. So there's geographic empanelment based on where you live to a 4 or 5 person provider team that takes care of this group of patients over a lifetime. And so it's comprised of a physician, which was incredibly important to them and something that they fought for over the voices of others who told them, your country's too poor to have doctors at these clinics. It's unreasonable and too expensive to put doctors in these primary care clinics. And Costa Rica thought that it was important and that their people deserved it. And they went ahead and did it with really good effects. So having a physician at the clinic made a huge difference in their ability to treat these more complex chronic diseases. They have a nursing assistant. They have a data registry person. So it was their job not only to check in the patient when they arrive, but also to create these long registers of patients with each condition. And then they have a community health worker. And I would say that this is where the magic happens, that there's able to be coordination between the community health worker and the physician and the entire team at the clinic to outreach to patients 1 to 3 times a year based on their risk and to do some of that follow-up. So this was before WhatsApp, right? This was 1995 to 2006. Instead of doing WhatsApp follow-up, they were able to knock on doors. And the Ministry of Health had this motto at the time that said, by foot, by boat, by horse, providers will arrive. Rural Costa Rica, getting to someone's house is sometimes a challenge. And I've been on these visits myself where the only way to get there was by foot and then by boat and then by horse up the mountain. And this commitment to meeting patients where they're at, to bringing them back into the clinic, that if your blood pressure is high and you haven't shown up at the clinic, the community health worker is going to go to you and they're going to bring a blood pressure cuff and they're going to help bring you back to the clinic. And so a multidisciplinary team model, extensive outreach by community health workers, and then again at the provider level, this population health management is done extensively. So saying, who are my sickest patients? Who have I controlled and not controlled? And what do we as a team need to do in order to achieve the health outcomes that we want to see for our patients?
Wow. Yeah, so much to learn from there, but also so intimidating because there is so much that is not done in other countries, right? And I think one thing I picked out is this idea of culture, and we've talked about this before, Maddie. The care culture within Costa Rica seems to be so different from that we've seen in so many other countries, where, as we've talked about before, it is a much more transactional relationship in many other countries, whereas in Costa Rica, it seems that is a lot more relational, right? And there is a sense of responsibility that the care team feels for the patient's overall well-being, which is not something that you often see in many other contexts. So I think all of those are important lessons for us as we think about how to design 21st century health systems. I know we are gone in depth into the models, and I think our listeners probably have a better sense of what it's all about. I want to spend the last maybe 30 minutes of our time talking more about how do we scale these approaches and how do we achieve systems change? Because the financing situation, as we know, is quite dire, right? In the global health space. A lot of funding is being cut. To start with, we had 2% of funding going to NCDs. God knows what we will end up with after all of these cuts go through, right? So with limited financing and with the burden of disease evolving as rapidly as it is, how do we really get to the systems change that we need? And does it also present an opportunity for us to reimagine our health systems, right? Because with the way that we have designed health systems over the last 50 years, maybe there was a component of the global aid funding that was driving or keeping things at status quo. Maybe with limited financing, there's opportunities to rebalance the power and the allocation of resources to be more in tune with how things actually should be. So with NCDs, we've talked about quite a few different angles here. Of course, there's the idea of prevention versus mitigation, like going from a traditional sick care system to a much more proactive system. And there is probably a case to be made that would be a lot more cost effective for health systems to be much more preventive, right? So that it does not escalate to that stroke that Rob was talking about. But there is a piece here about how do you redesign the provider landscape, both in terms of their skills and training. As you were mentioning, Maddie, providers need a different kind of training to be counseling patients, to be motivating them and to make the problem salient to them, right? That is not something that's taught in medical school today. So there are those components. But I think one of the things that really comes down to, and I've kind of seen this play out in my work in Bangladesh as well, is this NCDs bring to light this fundamental incentive gap between patients, providers, and payers, right? So you have insurance companies that are trying to, on the surface, they're supposed to reduce costs, but their business models are actually oftentimes based on getting the premiums and putting that in a bank and earning interest, right? With providers, the providers are paid for every transaction. So if they're being paid for every transaction and not being incentivized to actually proactively reach out to patients and follow up with them, they're not going to do it. ultimately people respond to incentives. With patients, we've talked about how poor people have that dual burden of having to put food on the table at the same time as doing prevention, which can be expensive sometimes. So how do you both make the problem more salient to them, as you were mentioning, Maddie, but then also make it more affordable and easy to do so that they can actually do it, right? So there are like all of these different things that needs to be adjusted. And I'm curious as to if either of you have any thoughts on, I know this is a big question. This is like a lot to wrap your head around, but are there any inklings that you have of like, how do we finance health systems differently, or things that you've seen in Costa Rica, for example, Maddie, how that the incentive alignment was actually achieved that you can share with the audience?
Maybe I'll go first. There's a 30,000-foot view of the global health landscape where you have some folks who are really working on the financing side to say, how do we get more money to spend in health systems? And I'm very grateful for those folks because in Kenya, on average per capita spend in healthcare is something like $80 or $90. So it is very, very small that's like your whole healthcare budget for the entire year. So we don't have a lot of money to work with. And I'm really grateful for the folks who are working on how do we increase that. The part that I work on and that Penda works on is, given that amount of money, how much can we do with it? And one of the big problems I see in the NCD space is, we have so many patients who do have high blood pressure, and they come to us taking a blood pressure medicine that costs $15 a month, and it's very expensive for them. Again, they might have bounced around between different specialists and gotten the same lab tests over and over. These are hugely wasteful expenditures when we have a very small little pot of money to work with. So let's let the folks who are working on increasing it, increase it. And then for us, how do we actually make that go as far as it can? And the aim for Penda and within this project of BP Sawa is we need to get the cost of treating blood pressure to as low as it possibly can be for the year. That's our goal, because that is the biggest barrier. I mean, you talk about incentives of payers, patients, and providers. In our case, the payers and the patients are basically one and the same. 90 to 95% of the continent does not have insurance. And at Penda, most of our patients are paying out of pocket with cash. So they are both the patient and the payer. So number one, demand generation, which is understanding like, why do I need to treat this condition? And number two, can we make that price point so ridiculously low that if we do a good job on demand generation, someone can look at their options and say, should I spend, $1 this month on these medicines that are actually very affordable and I can take one a day throughout the whole year? And then that can become an attractive value proposition. That's our goal. And I think as a provider, that doesn't necessarily make us big profits, right? And I think another maybe whole topic for us to discuss is like, what pieces of this ought to be grant funded versus funded purely from the business model. But our view, and I think, and I hope that you share this, is that to kick off this flywheel, we need some grant funding to support the initial kind of training and setup of the program and do that initial demand generation. And as that flywheel is moving faster and faster, it becomes something that is fully self-sustaining just through the business model when it's at scale.
That is a really important point, Rob. I'll go more into that, but Madeline, I'll come back to you. Do you have anything to add to Rob?
I think that Dr. Rob's perspective on this is thoughtful and reflects, this reality for so many patients. The only piece that I will add is that from a system level perspective, there's a lot of interest or belief in payment reform and an attitude sometimes that if we could just find the right formula to pay for this better, then all of our problems would be solved. But I think collectively, as a world, we have enough experience to say that if there is some super secret magical funding path that is going to fix all of our problems, we haven't found it yet. And so each funding path that we go down has benefits and drawbacks, and being really aware of what those benefits and drawbacks are is important. And certainly there are exciting, innovative, different ways to pay for things. At the end of the day, for many countries, if your total spend per person per year is even lower, if it's $40 instead of that 80 or 90, we are fundamentally not going to be able to provide enough care that every human deserves. So there is some gamesmanship, I think, that happens when your overall funding spend is too low to say, well, if we could just tweak it a little bit. So I do want to push back against that kind of global sentiment a little bit. And then I would also just acknowledge that in the countries where I've spent time and in the context that I've studied, financial incentives are short-lived, cause a lot of headache and trouble, cause a ton of administrative burden to operationalize, and rarely, if ever, lead to long-term behavioral change. And the business world figured this out 25 years ago. They know that these financial incentives don't drive sustained increase in productivity. And global health continues to come back to them as if they will be this savior that changes these fundamentally complex systems. So I instead continue to come back to Costa Rica's experience, where they did try financial incentives for specific quality metrics on a population level for about 7 or 8 years. And ultimately, as the 2008 financial crisis put additional strain on the system, the country decided to let go of these financial incentives. And the reason why was actually very, very beautiful. They said this commodification of doing our jobs well was not aligned with our values or the way that we see why we're providing care. And the commodification of providing high quality healthcare rarely leads to the type of behavioral, motivational, relational building that you want to happen. And so they have had incredible success with interpersonal motivations. You know, they have a publicly published list of quality rankings each year, and a ton of effort and work goes into performance on these quality rankings from a professional pride standpoint, from a patient care standpoint, and because they have worked really hard intentionally, put a lot of effort into defining that as part of the job. And so there are certainly job implications if a clinic performs poorly repeatedly year after year, but more than that, they have coaching. So for the bottom 20% of clinics each year, instead of some financial penalty or a lack of financial incentive, they get an assigned coach that says, okay, how are we going to do better next year? You know, for me, and I'm glad that there are people that spend their life on these financing models, and eventually, you know, there are better ones and worse ones. But I don't believe that there's a perfect financing model out there that's going to work our way out of this. So much like Dr. Rob's perspective, let's work with the financial systems we have, and there's ways to optimize population health in each of these financing models.
Such gems of wisdom both of you shared. Thank you both. So I want to kind of reflect back on what I just heard and maybe go to my next questions through that. So what I heard Rob say is that there's actually a simpler way of thinking about it, right? The simpler way of thinking about it is patients are often paying out of pocket for most of their healthcare anyway. The healthcare budgets are not really supporting them as much as they should. So there is incentive alignment there. And if we only drive down costs to the point where it becomes really affordable and we can do demand generation well, we can actually see great results. And you both shared examples of how that can be done. I think a layer on top of that is what Rob talked about in terms of the increase in health financing that's obviously needed. And in addition to that, the reallocation of health financing to more NCDs to be more commensurate with the burden of disease. So if, for example, Penda Health or organizations like Penda Health were able to drive down costs to like $1 a month, even then, maybe the poorest of the poor would not be able to afford it, right? And the poorest of the poor might need some subsidies from the government to be able to afford that treatment. And that's where governments have a role to step in, or donors for that matter. Maddie, you talked about that there is no silver bullet in terms of financing models. And I completely agree with you. I would only add maybe that in addition to, of course, thinking about incentivization more broadly, the frame within we operate does matter, right? So for example, if insurance claims and disbursement is the way you finance health systems, that's going to lead you down a certain path, right? Versus, let's say, capitation models, where you have an incentive to actually keep people in better health because that directly hits your bottom line, right? That might actually create a different set of incentives on the systems and the providers that ultimately, so for example, Rob, if you eventually had some sort of a subscription model for your NCD pathways, that might actually create direct financial incentives for you that hits your bottom line. And ultimately, of course, you do it for many other reasons as well, but for traditional health systems, creating those right financial alignments oftentimes might make the difference between putting in the effort versus not putting in the effort. But then the important point that Maddie made on top of that is that even when you have a financing model, that's maybe necessary, but not sufficient. So many other, like the cultural things, the values-based leadership that Costa Rica showed, those are the softer elements of care that oftentimes cannot be distilled down into a formula. And that is very contextual. That is very much based on the leadership and the culture and the values that people hold in that particular context. So I think those are extremely important points that you mentioned. I think a really important component to talk about today is the potential for technology to really supercharge a lot of the work that we're doing here. We especially live in a very, very exciting time where generative AI in particular is democratizing the entire space of clinical intelligence, where doctors traditionally had both a constraint and a monopoly on clinical knowledge, which is now being democratized. Rob, you do a lot of work with AI at Penda. So I am really excited to hear from you what you think true 21st century NCD response might look like, that fully takes advantage of the latest technologies that we have at our disposal. What would that look like?
Yeah, I'm also, just like you, very excited about this moment and what generative AI can contribute towards democratizing the playing field and helping us to achieve health equality. I think for hypertension, like specifically, it's not that hard of a problem. And so I actually think the decision support piece of it isn't really as transformative because these pathways are like very well established. We've known them for a long time. There may be areas where like nudges for clinicians to escalate medicines when they should, or to suggest alternatives may help, but a lot of it isn't so much clinical complexity that's the problem. It's much more, in my opinion, on the patient engagement side. And I think there, generative AI has a big chance to shine. And so a lot of what we're doing with our like WhatsApp platform with Penda is how can we give even more kind of hyper-personalized messages at the right time points and sort of automate that whole engine. We talked before about the funnel. If you do the hyper-personalization that generative AI allows you to do, does that allow people to flow down that funnel in like a much better way? And so to just give you an example of that, we are building out kind of a short onboarding for that WhatsApp so that we understand like how do people want to be talked to? You know, what are their exact language preferences? Is it English? Is it Swahili? Is it a mix? Is it more of a formal tone of a voice or more of an informal with emojis and slang and things like that? And I think when we can then bring those types of, you know, very hyper personalized approaches to the structured inputs that we know that people need at various points, like, hey, like we want to get your blood pressure, or did you know it was elevated and that these lifestyle recommendations are here? How do we tailor that in a way that's just going to have a very high chance of resonating with that person? Because the old school way is like everybody gets the same message, and that's fine. Maybe that works for 30% of people, but what if we could make it work for 90% of people? And generative AI gives us an ability to do that at a huge level of scale with a very low cost. So that's like a big part of our approach with BP Sawa. And I think at the end of the year of the scale up, we're going to have a big story to tell about how that works in practice.
That's super interesting, Rob. Yeah, I think engagement is such a solved problem, right? Like Facebook has figured it out 15 years ago. And yet within global health, we are still struggling to adapt some of those techniques and technologies. It was even pre-generative AI that we figured out engagement issues, right? And now we have the power of this tool that can speak your language, your dialect, even talk to you in voice, like all of the things that enables it to be so much more personalized, so much more personable and approachable. And of course, virtually free, right? So in lieu of having a human call center agent having to have a call and really understand the patient's personal context and personalizing the message, you're actually doing this almost automatically for cents on the dollar. So there's just such tremendous potential to be able to drive down the costs of that patient engagement and demand generation. That's truly incredible. And of course, with more complex diseases, you can do much more on the supply side as well, where the clinical decision support, as you are testing, we don't have time to talk about today, but there's some exciting stuff happening on that front as well. I think there's another angle to this, which is on the population health management side, like at the system level, if you had AI that was actually monitoring the entire population, right, and identifying where are the risk pockets, where are the people that actually need targeted follow-ups and treatment. And those are the kinds of things that you can start to do now with generative AI, which is clinically intelligent. And of course, combine that with the traditional machine learning models that you can train on your entire EMR record, for example, and be able to predict outcomes ahead of time. There's just so much more that can be layered on in terms of like systemic intelligence, as we call it, that is completely untapped at this point. So I'm super excited as platforms like Penda already have so much knowledge and data to train these models on, to see how that space actually evolves and how we can actually deploy this general purpose technology that we have in our hands to great effect in managing things like NCDs. Of course, any conversation with technology is not complete without talking about, is it really sufficient, right? So Maddie, I'll come back to you to talk about a little bit about what is the right balance between these high-tech solutions and fundamental like systems thinking and system redesign and the kind of things that you talked about in terms of culture and values. What is the hardware and what is the software?
Absolutely. So two things that stand out to me from what you've been saying that I'm most excited about. So the first is that cognitive offloading for clinical decision making, like we alluded to, leaves time for this extra work that we're asking of clinicians to do. So if you're not worried about getting the diagnosis right because you know you have a backstop, if you're not desperately trying to remember what the exact dose of this exact medication is, it frees up space for you to think about that motivational interviewing piece. It frees up space because you don't have your back to the patient trying to type your note out as fast as you can because you now have ambient listening that's going to transcribe this for you. It frees up that cognitive space and time to do this extra task that we're asking of clinicians to create this longitudinal relationship, to focus on how to motivate this patient to do really hard things, to make hard decisions, and to do fundamental lifestyle changes. So I'm really excited for this additional time and space, not so that providers can see more patients faster, but rather so that we can do the things that we've been talking about that make non-communicable diseases better. So that's the first thing. And then I think your point about population health management being enabled by AI is what is most exciting to me right now. I think doing it by pen and paper, the way Costa Rica did in early 2000s, takes a lot of time, a lot of money, and a lot of cost. And so I am really excited as we talk about democratizing population health management to the provider level. When we think about contexts like Sierra Leone, where the average literacy and data literacy of community health workers may not support them doing kind of complex statistical modeling. How can we use AI to supercharge those providers to identify the needs of their population, to make sense of data, to ask natural language questions and get natural language answers about who should I prioritize for my visit today? What area should I go to? What houses should I see? Those sort of questions about democratizing not only the clinical information that physicians have held so long, but also the public health information that has for so long been behind doors and behind layers of epidemiologic statistical modeling that many folks couldn't really utilize on a day-to-day basis. So those are the two areas that I'm most excited to see technology create change and space and improvement. There is this other side of things that says, technology will only take us so far. And there is a fundamental need to invest in this strengthening healthcare systems, cultural change in how we conceptualize what a healthcare system should be, change in what patients expect from their healthcare system. And we talk about no silver bullet for financing models. I don't think AI is a silver bullet to fix under-resourced health systems that serve humans that deserve more from us. So I don't think it absolves us of our moral responsibility to improve healthcare systems, to improve financing, to ensure that every patient everywhere gets the high quality care that they deserve. But I like the concept of a supercharge or a boost, right? It does enable us to do more with the time we have, but it doesn't absolve of our fundamentally human responsibility to improve the care systems across the globe.
Such a beautiful thought. Thank you, Maddie. If you had to conclude our conversation today with one key thing, like if I had to frame it, like if you had a magic wand, for example, and change one thing about how health systems approach NCDs and this entire continuity of care and preventive proactive approach to caregiving that we've been talking about today, what would that be? I'll go to Rob.
For me, it's broader public education campaigns. That's a role that Penda ourselves cannot play. And if governments and maybe other actors play that role of helping people understand what the problem is, why it's important to treat it, and what good treatment looks like, then you actually end up solving a lot of the other issues, because then the demand is there. And so then all of us as providers, whether that's in the public sector, the private sector, the individual clinicians, et cetera, we will align ourselves to meet that demand. But it's very hard to try to create the apparatus and create the demand at the same time. So my hope would be better public health campaigns so that patients are engaged and informed and can demand the right things from the healthcare system.
A really important point. Thank you, Rob. Maddie, we'll come to you for your parting thoughts.
So those of us who know me well, I think will not be surprised by this answer. For me, the linchpin in this change from a reactive to proactive system is empanelment. And, I smirk because, my friends say, why are you so obsessed with empanelment? Why do you keep coming back to this concept? And for me, if we are unable to build those longitudinal relationships over time with the same provider who gets to know you and your values, if we are unable to pivot from waiting for patients to arrive, the only way that we can figure out who needs us is knowing who we're supposed to be looking after. And so this switch to proactive care, I think, necessitates understanding who you are responsible for. And when you have a discrete population that, as a provider, as a clinic, as a district, as a country, that you are taking responsibility to say, how can I make their health outcomes the best that it can be? This proactive care can follow, the relationships, the continuity can follow, the type of care that every human deserves can follow. And so I think empanelment to me is that first starting point to reorienting the healthcare system around chronic diseases. And we spent a lot of time talking about non-communicable diseases, but we have a huge avalanche of infectious chronic diseases to manage and navigate as well. Tuberculosis takes months to fully cure, and multiple drug-resistant tuberculosis can take even longer. HIV is a lifelong disease that requires continuity of care over time in these relationships. So in order to really change our healthcare systems to address these chronic needs over time so that patients are preventing health outcomes 10, 20 years in the future, those relationships and that perspective comes back at the end of the day to patients knowing who their provider is and providers knowing who their patients are. And that type of relationship is most easily developed when you work with a system that has empanelment.
Wow. Yeah. So well put. Like, empanelment sounds like a very nerdy term, but when you put it that way, that really makes a lot of sense.
It is a nerdy term.
Thank you so much for nerding out with me on NCDs today. This has been such a pleasure, and I've just thoroughly enjoyed working with you and knowing you both over the last year or two. I think we dived into a lot of very important topics, and we brought out a lot of very important themes in the NCD conversation. I think this will be really enriching for the audience. So I'm super excited to follow both of your work and to continue to support in it whatever way we can. Thank you so much both, and have a great day. Bye-bye.
Thank you.